The next talk is by Shail Vesavada on optic capture to the rescue in special situations. Shail
Yes, sir.
is a very prominent surgeon and very skilled surgeon, so let's see what he has to offer.
So we do receive research grant support from Alcon Laboratories. This was a 53-year-old male, right eye grade 2 cataract, nothing very significant. His left eye was already operated few months back, and we had planned a femto cataract with the toric IOL. Everything went off well as per plan, and now we are ready to implant the toric IOL, T3 model in this case. This is all in retrospective. The rexis is perfect, the capsule is perfect. The only thing that was amiss here was that the plunger of the injector was actually overriding on the optic haptic junction. Ideally, the plunger should be at the optic haptic junction. So I'm feeling some resistance while injecting, but I thought I'm okay. I can manage this. I'll be slow while inject in the end. And eventually, in the end, I had a shoot. So one learning first of all was that if you're in doubt, just pull back and just look what's going wrong, and try and do it again, which I did. Now still I'm not feeling very bad because I filled the eye with a good quality cohesive viscoelastic, and I said yes, there is a jerk, but it's okay. It's a cohesive viscoelastic, and nothing will have happened. This has happened to me before. And so I'm still not very concerned, and fortunately the IOL is opened up slowly, and I've placed it nicely in the bag. So I have a nice toric IOL now inside the bag, covered by the capsulorhexis, but I start seeing a little flap here, and that is the flap. That is the area where the jerk has hit and created a posterior capsule rupture extending up to the equator. So there is unfortunately no way where I can try and go below the IOL and convert this into a posterior capsulorhexis. It is right extending here and up to the fornicis. So now I'm in a little bit of a difficult situation. So I have a single piece IOL in the bag, and that IOL is a toric IOL. And now the treatment options for me to consider, what can I do for this eye? So theoretically, ideally, if there is no good posterior capsule support, a single piece IOL should not be placed in the bag. So I know that. Now the option is to, if I want to try and remove this IOL, if I want to try and explant this IOL and then put a 3-piece IOL, I'm likely to cause a lot of manipulation, maybe disturb the vitreous, which it is not at the moment, and cause more corneal edema, increase the incision size, refractive outcome, so on and so forth. So having had some experience with conventional optic capture, I thought this is something that is worth considering, what is described as the reverse optic capture. So in conventional optic capture, what we have is that the haptics are in the sulcus, and we push the optic below the anterior capsulorhexis so that it stays away. So in the reverse optic capture, what we are trying to do is we are keeping the haptics inside the bag, but we are trying to pop up the optic above the anterior capsulorhexis. So first, before doing that, I want to make sure that I position the IOL appropriately at its toric IOL placement axis, because that's the reason why I'm keeping this IOL in the bag, to correct the astigmatism as well. And then what sorry for that, Eviglis. So then I'm going below the IOL and trying to push up this optic above the anterior capsulorhexis, so that the optic stays above the anterior capsulorhexis, but the optic haptic junctions and the haptics stay behind the anterior capsulorhexis. And why is this important? Because it is the optic haptic junction and the haptics of a single piece IOL which are large and bulky, and they are the ones which irritate the ciliary body, cause uveitis, hyphema, glaucoma, and therefore it is recommended to never place a single piece IOL in the sulcus. So this is something that we were able to achieve in the end. This ovalization is a sign that this part has been captured, so the optic is above the anterior capsulorhexis. Unlike an conventional optic capture, here you will have a broad ovalization at the bases, because the optic haptic junction is very broad. And fortunately, we were able to achieve this optic capture, reverse optic capture, and place the IOL consistently in its position in the bag. And this is how the patient looked several months post-operatively, stable. The IOL obviously has not rotated, cannot rotate because it is locked in its place. And because there was already a pre-existing PCR, PCO also did not develop few months later. There was fortunately only a slight myopic shift. Because the optic is anterior, you may get a myopic shift of about minus 0.25 to minus 0.5. But generally, if you end up slightly myopic, you are unlikely to make the patient unhappy rather than if you end up with hyperopic. So the patient was very, very happy. This was the second case, again very interesting, 62-year-old female, right eye cataract surgery done elsewhere, beautiful surgery, perfectly done rexes, well placed single piece IOL hydrophobic acrylic in the bag. But the patient is extremely bothered with negative dysphotopsia, and the surgeon correctly, recounseled her, reassured her 3 months, 6 months, year down the line. But she's just not ready to accept the negative dysphotopsia. And now she's getting bothered because the other eye vision is getting worse due to cataract. But she's extremely wary that she just does not want negative dysphotopsia in the other eye. So she has come to us that do something first for this better eye, then we'll think what to do with the other eye. But I can't see well with this eye, I need cataract surgery, but definitely this is something that I don't want to tolerate. So she needs cataract surgery, but wary of negative dysphotopsia. So what should be the plan, IOL type and design? And there are several articles on the surgical management of negative dysphotopsia. And the theory is that if you have the optic above the anterior capsulorhexis margin, the chances of negative dysphotopsia are negligible. So conventionally, that would just mean a 3-piece IOL in the sulcus will never get a negative dysphotopsia. There are now special IOL designs, single-piece IOL designs of specific designs which can fix on the capsulorhexis and the optic stays above. And reverse optic capture would probably achieve that with the optic staying above the anterior capsulorhexis. Now the catch here was the patient had significant astigmatism. So in trying to reduce the negative dysphotopsia, we may end up leaving behind astigmatism if we do a 3-piece IOL in the sulcus, and then she'll be unhappy with the poor unaided quality of distance vision. So we reassured her, we counseled her that this is not something very serious. We'll try our best to not have that in the other eye, but you could still have in spite of all our possible efforts. And the plan was once again to do a single piece toric IOL and do a reverse optic capture. The most important thing of the surgery is to have a good smallish anterior capsulorhexis, because if the anterior capsulorhexis is large, the optic will not capture. So it is a struggle to do a reverse optic capture of a single piece IOL, and one side was done, the other side came off, and I had multiple maneuvers, multiple times I had to do it, and eventually I could achieve that reverse optic capture. This is, as you can see on OCT, fused margins of the rhexis with the optic above. And this is post-op 6 months, no negative dysphotopsia fortunately, and she's forgotten the negative dysphotopsia in the other eye. Obviously, she will develop PCO early and will need YAG. So I think reverse optic capture of a single piece IOL, although difficult, is possible. So I think it's something that we as surgeons need to keep in our surgical armamentarium for various situations. Of course, the optic is closer to the iris, so these patients need a close monitoring at least in the early post-op, and we'll need more anti-inflammatory and maybe IOP lowering treatments in the early on period. Thank you so much for the patient listening.
Thank you. Shell, what is the physics behind this? I mean,
so, sir, I read it every time when I make this presentation, but I still always forget why the negative dysphotopsia occurs. So
no, why by a capture does it get relief?
So yeah, so sir, the thing is that the rays passing through the nasal retina, they sort of, if the nasal retina is too anterior, that's how it occurs. And when it passes through the edge, and therefore the treatments recommended are, YAG capsulotomy on the nasal side of the capsulorhexis margin, or just if the entire 360 degrees of the optic margin covers or is above the capsulorhexis, it will not allow it to refract through it. That's the possible theory.
And this is a known treatment or you tried
yes,
it out?
Sir. No, sir. Reverse optic capture has been described.
For this condition?
Yes, for negative dysphotopsia, but it was always done with a 3-piece IOL design, not with a single-piece IOL design.
Thank you very much.
I think it is the gap which is left between the IOL edge and the nasal nasal area of the equator of the cataract. It is the gap. So how come doing the reverse optic capture reduces that gap?
So, sir, the optic is now above the capsulorhexis margin, and to be honest, sir, I really don't understand. I've read Dr. Holliday's paper several times. I've heard Dr. Ramamurthy sir's talk regarding this also several times, but I still, it's not something that I can explain very well.
Yeah, I would agree. I would agree. Reverse optic capture is a very good thing for toric lenses, because toric lenses, you don't have the ability to put the haptics at 3 and 6 o'clock, which stops you from getting 3 and 9 o'clock, which is what stops you getting negative dystrophy. You've got to move it around to wherever the axis is. So I do reverse optic capture a lot, particularly if the haptics are not at 3 and 9 o'clock. The one surgical pearl is make sure you get rid of all the viscoelastic, because the viscoelastic doesn't come out because it's stuck behind the IOL in the back. Normally we expect it all just to come out. So you've got to actually physically go behind the optic to get the viscoelastic out at the end. And you can get caught out with a big distended bag with the viscoelastic shifting the lens forward and causing a refractive error.
Sir, you were going to share your
Mahmood.
Basically, what's postulated is the rhexis margin overlapping the square edge of a hydrophobic acrylic lens. And some of the rays of light which come there get reflected back and onto the nasal retina. When it hits the nasal edge, then it gets reflected back to the temporal retina, and that causes positive dysphotopsia. But at the same time, there is also an area of darkness which is there in the nasal retina. And as he said, if the retina is extending forward, that can happen more frequently, and that causes a dark shadow. So the idea is to get rid of this overlap of the rhexis margin onto the square edge. That's why either you YAG that, or sometimes because the pupils don't dilate that well, you cannot visualize that. Then, as Shail nicely demonstrated, you can do a reverse optic capture, or you put a sulcoflex lens of about 6.5 millimeters, which has a rounded edge and overlaps that square edge. Other thing is, now we have this ND ring, negative dysphotopsia ring, which is essentially just a ring of 6.5 millimeters which can be positioned there, covering that area. I have actually tried all this. Of course, the number of cases are very few, and it gets elevated.
So ideally, we should not have the absolute square edge lenses, because this used to be the concept in the beginning, that have the square edge, so that you reduces the formation of capsular opacity, PCO. But now I think nowadays that the concept has changed, because don't keep absolutely square edge. You have a what you call surface which is modulated, and to reduce the negative dysphotopsia.
It's good to discuss this, but then it's supposed to occur in 17% of the cases initially, but 97% of them disappear over time.
Yeah.
So hardly 1 in 100 cases really bothered by this.
So the progressive opacification of the anterior capsular margin actually takes it away. So the less the exposure of the square edge to the incoming light is what is important. By reducing the distance between the posterior surface of the iris and the anterior surface of the optic, you're essentially reducing the edge exposure to the incoming light. That's how this reverse optic capture works.
Thank you.
The thing is, make sure you leave the haptics at 3 and 9 o'clock. We did that across the board in our facility, and we really reduced the instance of it, and it's much less of a problem with the instance of just because we all forget to do it. But now it's brainstem for me. Put the haptics at 3 and 9 o'clock.